All right, hello. Welcome to week 2 content session. This is for NU621 Advanced Pathophysiology. My name is Dr. Christy Burks. As a reminder, if you have questions or need to reach out to me, email is the best way to do so. If you are able to email from the course within the inbox, this helps actually identify which course section you are in. If not, and you're emailing from Outlook, please include the section that you're in for NU621, okay? All right, as another reminder about the resources available to you, you do have the synchronous session schedule and links announcement. Remember that you have those supplemental PowerPoints. You have optional journal articles and or resources as well. You have the ebook. The textbook is great. It has additional um, resources for you to utilize in there. So please remember utilizing those as well as that library link, which leads you to those 3Ps resources, which include those 4 additional books. Okay. You can, again, you can go to the library link, or you can go to modules and go to that read me first and go down to that last page and get to that link quicker. Okay. All right. This just shows you if you click the library link, you have to go into research guide, and then go to, I think it's, yeah, graduate student nursing or student guide for nursing, and that will lead you to it. All right. So, looking at the resources available, you have the textbook, which is the topic included in your reading assignments. And then for this topic, I'm going to also refer to those other additional ebooks that you have in those 3Ps. The first is an image from Just the Facts Pathophysiology ebook, and it's a basic algorithm for the format of how DIC occurs. So that disseminated intravascular coagulation, define and explain its underlying mechanism. So DIC, we know, is a life-threatening condition where the body's blood clotting mechanisms are abnormally activated. So that leads to that widespread clotting and depletion of clotting factors and platelets. The underlying pathology of DIC involves excessive thrombin generation, leading to that widespread microvascular thrombosis and subsequently that consumption of platelets and clotting factors. Now, the excessive activation of the coagulation cascade results in formation of numerous microthrombi throughout the body's microvasculature. This process rapidly consumes that clotting factor and platelets, and that leads to their depletion and subsequently bleeding complications, which are very characteristic of DIC. And that often triggered by conditions like sepsis, trauma, malignancy. We see that in OB complications, and other causes can include like heat stroke, cardiac arrest, cirrhosis, and even incompatible blood transfusion. When we see or think about DIC, that underlying condition such as sepsis or septic shock, trauma, or even cancer, we see that it triggers the release of pro-inflammatory cytokines, like interleukin 1 or IL-1, that tumor necrosis factor alpha, the TNFA, and even interleukin 6 or IL-6. Those cytokines which cause that widespread endothelial damage and activation, and that's what's disrupting the normal anticoagulant properties of the endothelium. Now, these endothelial cells become procoagulant, and that expressing tissue factor, which indicates the extrinsic coagulation cascade. And this leads to that systemic thrombin generation or fibrin deposit and microvascular thrombosis. And the excessive clotting consumes platelets and clotting factors, eventually resulting in the bleeding complications as well. Now, this image, or this next image, is from the Pathophysiology Made Incredibly Visual ebook. And it's a great visual aid showing that process of the tissue damage in DIC. And the next image is the process of an endothelial damage in DIC. Let me get over to that. Okay. Now, if we think about list and describe those complications of DIC. So our complications of DIC include thrombosis, which we know that formation of blood clots that can obstruct blood vessels, leading to organ damage and ischemia, thrombotic complications like stroke or myocardial infarction, pulmonary embolism due to clot formation. We see hemorrhage, which is that depletion of clotting factors and platelets can cause uncontrolled bleeding from multiple sites, and hematomas and GI bleeding. Organ failure or dysfunction due to the microvascular thrombosis. Clots can impair that blood flow to vital organs like the kidneys, lungs, and brain. Shock due to severe bleeding and impaired tissue perfusion. And then that consumptive coagulopathy, which leading to that depletion of clotting factors and platelets, which we then see increased risk of infection due to that immunosuppression. We do need to understand the labs associated with diagnosing DIC. So if we think about that, we've got the prolonged prothrombin time, PT, and activated PTT, the low fibrinogen levels, elevated D-dimer levels, low platelet count, thrombocytopenia platelet count below that 150,000 per microliter. Remember, as the platelet count decreases, the risk of bleeding increases. Severe thrombocytopenia is a count below 20,000. This is when spontaneous bleeding and potentially life-threatening hemorrhages can occur. Presence of fibrin degradation products. So key laboratory findings in that DIC include that thrombocytopenia, prolonged PT and APTT, decreased fibrinogen levels, and presence of fibrin degradation products like D-dimers, and that's when we see that. Additional tests can show anemia, elevated bilirubin, and organ dysfunction markers. So now this next image is the image process of endothelial damage in DIC. So again, these are all visuals from those two ebooks. Let me go back here. I think I had one more I want to talk about. All right. So when we look at this image, it displays a visual of one DIC with thrombotic phenotype and DIC with fibrinolytic phenotype, because DIC can present with two different types of phenotypes. So DIC with thrombotic phenotype is characterized by excessive clotting and thrombosis. In this form, there's widespread microvascular thrombosis leading to that organ dysfunction and ischemia. The predominant clinical feature is that thrombotic complications like the stroke, pulmonary embolism, and organ failure. And then the second, with DIC with fibrinolytic phenotype, is characterized by increased fibrinolysis, or that breakdown of clots and bleeding. In this form, there's excessive activation of the fibrinolytic system, and that leads to the breakdown of those clots as they form. And the predominant clinical features are that bleeding complications like the mucosal bleeding, hematomas, and hemorrhage. Now, when we think about what is happening to the body that causes these lab changes and complications. So in DIC, the body's inflammatory response triggers excessive activation of that coagulation cascade. That's what's leading to the widespread clotting and consumption of clotting factors and platelets. This results in the formation of numerous microthrombi that can obstruct those blood vessels, causing that organ damage and ischemia. Simultaneously, that depletion of the clotting factors and platelets increase the risk of uncontrolled bleeding. So again, clinical manifestations, the DIC include the cutaneous oozing of serum, bleeding from multiple sites like the mucosal, venipuncture, surgical. We see petechiae, ecchymosis, cyanotic, mottled fingers and toes, confusion, dyspnea, organ dysfunction, and then we see our strokes, renal failure, respiratory distress, and even shock. So severe DIC can lead to multi-organ failure as well. When we think about DIC and lead to that widespread clotting and consumption of clotting factors, that DIC leads to the widespread clotting and consumption of clotting factors because the coagulation cascade is excessively activated. and that causes excessive thrombin generation and fibrin formation. So this process rapidly consumes clotting factors, leading to their depletion and subsequently the bleeding complications. Now, prompt treatment of that underlying cause and supportive care with blood products, transfusions are crucial at this point. And this is to help prevent either continuation or further serious complications that we see in DIC. Now, severe uncontrolled DIC has that high mortality rate. So the treatment of DIC involves addressing those, again, the underlying causes, providing that supportive care. So we see treating the precipitating condition. So whether it's sepsis, trauma, or malignancy, just as those examples that have triggered something, whatever's triggered the DIC. Supportive care could be with blood products and transfusions. So we might see FFP or fresh frozen plasma to help replenish the clotting factors. Platelet transfusions for thrombocytopenia and or packed red blood cells to support hemostasis and active bleeding. Additionally, in some cases, low-dose heparin may be administered to modulate the coagulation cascade and prevent further thrombosis. Supportive care for organ dysfunction or failure due to the clotting or bleeding complications as well. Remember that primary goal is to stop the ongoing coagulation process, and that replacing that depleted clotting factors and platelets, and that helps manage any bleeding or thrombotic event until the underlying cause is resolved. Now, looking at different types of anemia, we do have an assignment this week that will help you with this as well. And I do encourage you to explore and dive deeper into the anemia assignment. So one, it can help you study for this as well. When looking at the different types of anemia, we should be able to describe the pathophysiology, the clinical manifestations, the lab findings associated with each type of anemia as well. This first image is from the textbook in table 29.2, which is, it reviews the classification of estimated blood loss. So anemia of acute blood loss. So post-hemorrhagic anemia is that normocytic, normochromic anemia. This can be seen in our traumas or surgery patients. Remember, there's mostly a loss of intravascular volume, but if severe or rapid enough, it can lead to cardiovascular collapse, shock, and even death. So in table 29.2, it does a great job of portraying that classification of estimated blood loss with the amount of loss per volume, resulting in what might be seen in a patient's pulse rate, systolic blood pressure, pulse pressure, respiratory rate, urine output, and even mental state, and the initial fluid replacement needed. Now, when we look at the next figure from the textbook 29.1, it's the classification of anemia. It does a great job of breaking down the anemias. This actually may help you. This actually may be helpful when you're looking at the assignment for week 2 as well. Anemias can be classified into 3 different categories or 3 major categories: acute blood loss, decreased red blood cell production, in which reticulocytes are decreased, and increased red blood cell destruction in which reticulocyte counts are increased. So further classifications relies on the size, which is that cytic or color, chromic, and shape of the cells. So based on these factors, the most common types of anemia can be identified. So anemias can be identified again by based on the size of red blood cells. As microcytic, we see small. Normocytic is those normal size, and then macrocytic, which is those larger size red blood cells. Now we're going to start with megablastic anemias, which are those macrocytic anemias. So megablastic, classified as the macrocytic anemia because it leads to large immature red blood cells due to deficiency in vitamin B12 or folate required for DNA synthesis. So the lack of the intrinsic factor is directly related to the development of pernicious anemia, which is a type of macrocytic anemia. So intrinsic factor is a glycoprotein produced by the parietal cells of the stomach. It binds to the vitamin B12 and facilitates its absorption in the terminal ileum of the small intestine. Without intrinsic factor, vitamin B12 cannot be properly absorbed and this leads to that deficiency. Now, the vitamin B12 deficiency impairs the DNA synthesis and results in the formulation of large immature red blood cells or macrocytes, causing the macrocytic megablastic anemia known as pernicious anemia. Therefore, the absence of or lack of intrinsic factor is the primary underlying cause of pernicious anemia, a macrocytic anemia, characterized by that large abnormal shaped red blood cell. An example disease process might be someone with Crohn's disease. So if we think about that, it can lead to vitamin B12 deficiency anemia. Crohn's is that inflammatory bowel disease. We'll talk further about it in the coming weeks. But that bowel disease that can affect that terminal ileum, which is the site of vitamin B12 absorption. So inflammation or surgical resection of the ileum impairs that ability or the body's ability to absorb vitamin B12 from food sources. And over time, this malabsorption results in vitamin B12 deficiency and the development of macrocytic megablastic anemia. Now, monitoring our B12 levels and providing supplementation is an important part of managing nutritional complications in Crohn's patients. So remember that when we get into further discussion about Crohn's. Now, on this next image, the next two images are pulled from Just the Facts Pathophysiology ebook. Now, pernicious anemia is a type of megablastic anemia caused by that vitamin B12 deficiency due to that lack of intrinsic factor, which is essential for that B12 absorption in the ileum. Now, impairing the DNA synthesis and red blood cell maturation. Patients can experience fatigue, pale skin, smooth tongue, numbness, tingling, and even poor balance. And sometimes we even see dementia, like cognitive impairments. Your lab findings include macrocytic anemia, elevated MCV, or that mean corpuscular volume, and low serum B12 levels. When we look at folate deficiency anemia, which is another form of megablastic anemia, inadequate folate impairs DNA synthesis and red blood cell maturation. This leads to fatigue, weakness, shortness of breath, and diarrhea. Lab tests may show that macrocytic anemia, elevated MCV, and low serum folate levels. Next, we have iron deficiency anemia. It's a microcytic hypochromic anemia caused by insufficient iron for hemoglobin synthesis, resulting in those small, pale red blood cells. Patients experience fatigue, weakness, pale skin, headaches, and even brittle nails. So lab findings, you may see that microcytic hypochromic anemia, low ferritin levels, and even high total iron binding capacity. The next one we're going to talk about is our vitamin B12 deficiency, which we talked about. It definitely can be associated with Crohn's disease. A couple other example disease processes it can be associated with is like our celiac disease, gastrectomies, even our strict vegan diets sometimes can impair that B12 absorption and intake. So just remembering that. Anemia of inflammation, also known as anemia of chronic disease. It's a normocytic, normal in size, but red blood cell. So normocytic, normochromic, which normochromic we know is normal hemoglobin content anemia, associated with conditions like TB, osteomyelitis, chronic kidney disease, cancer, COPD, and even our congestive heart failure patients. Now, chronic inflammation impairs or disrupts the iron utilization, metabolism, and erythropoietin red blood cell production, that leading to fatigue, weakness, and even that paler skin. Lab tests may show that normal or high ferritin levels and low transferrin saturation and normocytic, normochromic anemia. So elevated inflammatory markers like C-reactive protein or CRP, or that erythrocyte sedimentation rate, that ESR. You see the normal MC or even normal MCHC as well, that mean corpuscular hemoglobin concentration. Patients with anemia of inflammation typically have a low hemoglobin level, that underlying inflammatory process suppresses the red blood cell production. This leads to a decrease in the hemoglobin concentration in the blood. However, the hemoglobin levels are usually only mildly to moderately low compared to other types of anemia. So, a low hemoglobin, along with those normal red blood cells, and evidence of inflammation, is characteristic of anemia of chronic disease or anemia of inflammation. Hemolytic anemia, it's one that's classified by based on the mechanism of increased red blood cell destruction, which can be inherited. So we think of sickle cell, thalassemias, where they're acquired. Now, sickle cell anemia, classified as inherited, causes that abnormally shaped sickle red cells prone to hemolysis. Now, episodic pain crisis, fatigue, jaundice, growth or delayed growth, stroke, and even acute chest syndrome can be some of the signs. Thalassemias cause that chronic hemolytic anemia with abnormal red blood cells, morphology, and variable clinical severity depending on the number of affected genes. So, proper classification guides, monitoring transfusion needs, and management of complications like iron overload. Some of the symptoms include that pallor, fatigue, jaundice, poor growth, skeletal deformities, and even an enlarged spleen. Aplastic anemia, it's one that's classified as a type of anemia with decreased red blood cell production due to bone marrow failure. It's a rare and serious condition characterized by a failure of the bone marrow to produce enough new blood cells. So it leads to a deficiency of the red blood cells or the anemia, white blood cells, leukopenia, and platelets, thrombocytopenia. The main cause is the autoimmune attack on the stem cells in the bone marrow. So it can also be triggered by exposure to certain chemicals, radiation, and even viral or viral infections. So some of the symptoms include fatigue, frequent infections, easily bruised or bleeding. Without treatment, this can be very life-threatening due to the increased risk of uncontrolled bleeding and infections. Recognizing the types of anemia based on clinical presentation and lab findings is very important for appropriate management and treatment. So, understanding what you're looking for. Now we're going to look at cardiovascular disease. So we're going to look at STEMI versus non-STEMI. So ST elevation myocardial infarction versus non-ST elevation myocardial infarction. So we need to differ in their underlying pathophysiology and severity. So the key differences between non-STEMI and STEMI lies within the extent of the myocardial injury and the pattern of the coronary artery occlusion. So when we think of STEMI, it's caused by a complete occlusion of a coronary artery due to a ruptured atherosclerotic plaque and thrombosis formation. This leads to transmural or full thickness myocardial infarction extending from the endocardium to the epicardium or through the entire thickness of the heart muscle. So the ECG shows the ST segment elevation, indicating that significant myocardial injury. When talking about a STEMI, there are 3 coronary arteries that provide blood to the heart muscle. So depending on the blockage, if it is in the anterior, if it's an anterior STEMI, the blockage is in the left anterior descending or the LAD. Or inferior or lateral STEMI, either in the right coronary artery, RCA, supplying that inferior, the bottom part of the heart, or the left circumflex, the LCX artery, which supplies the side of the wall of the heart. Then we look at non-STEMI, on the other hand, where it is caused by a partial or temporary occlusion of a coronary artery. So this leads to myocardial ischemia and injury limited to that endocardial layer, inner layer of the myocardium, so of the heart muscle. So the ECG may show ST segment depression or even a T wave inversion, but no ST segment elevation. And non-STEMI is considered less severe than a STEMI, but still carries a lot of risk of recurrent clot formation and even further myocardial damage. So If we think about risk factors, we need to think about it in modifiable versus non-modifiable factors. So we think about some modifiable factors as tobacco using or smoking or vaping, um, diet where it's high in sodium intake, sugar or fat, cholesterol, physical activity, recreational drug use. Those are all modifiable versus our non-modifiable, which as we age, it increases our risk of heart attacks. So even sex, so men 45 and up and women 50 and up increases that risk, and those are non-modifiable. Family history, your risk goes up if you've had a family member like a father or a brother diagnosed with heart with a STEMI or non-STEMI, or an MI before the age of 55, or if you have a mother or sister diagnosed before the age of 65 with it. Now, inherited or congenital conditions, like the Cleveland Clinic states, about an estimated 780,000 cases of acute coronary syndrome are diagnosed each year. So about 70% of those are non-STEMIs. Now, thinking of symptoms, we know chest pain is one of the big ones. So angina, shortness of breath, nausea, stomach pain, similar to indigestion sometimes, heart palpitations, anxiety, or that impending doom, dizziness, lightheadedness, and even fainting. So how does, when we look at and think about the key differences in the pathophysiology that lies in the nature of the coronary artery obstruction. So let's look at that. I think I have, the algorithm 32.4, which shows the pathophysiology of an acute coronary syndrome. So in stable angina, there's a fixed atherosclerotic plaque that partially obstructs the coronary artery, and that leading to that reversible myocardial ischemia during periods of increased oxygen demand. So in unstable angina, there's a disruption or erosion of atherosclerotic plaque, causing that intermittent, complete, or near complete occlusion of the coronary artery by a thrombosis. This leads to that unpredictable episodes of myocardial ischemia, even at rest. So the thrombosis is labile and can temporarily occlude the vessel for 10 to 20 minutes before dissolving, allowing reperfusion before significant myocardial necrosis occurs. Now, an unstable angina signals that the atherosclerotic plaque has become unstable and is at a high risk of causing that myocardial infarction. In women, they can have insomnia, fatigue, shortness of breath, pain that radiates to the back, shoulders, jaw, neck, arms, or even in the belly, nausea and vomiting. So it's very important to get EKGs, CT or MRI labs checking troponins. When we think of treatment, we think of that PCIs like percutaneous coronary intervention, which is very time sensitive. So we have that door to balloon time, where we look at the time it takes for the patient to go from the ED, emergency department, to undergoing that PCI. Faster is better. We know medications can include those beta blockers to help reduce how hard the heart pumps and slows the heart rate to help the heart muscle handle the reduced blood supply and reduce damage to the heart. We see statins to help lower cholesterol and almost stabilize that plaque if it's there. Aspirin and antiplatelets. So that helps reduce the formation of blood clots on plaque, or if a stent is in place, it prevents the clots from forming on the stent itself. Anticoagulants, which help the clotting differential or different than helps with clotting differently than the antiplatelet drugs like aspirin. We've got nitroglycerin, which is that vasodilator that helps with the chest pain or angina. Pain medications like morphine we see used. And then for severe blockages, the patient may have to have or undergo CABG or coronary artery bypass grafting. This last image is the last image is from the textbook. It's table 32.5. It describes complications of an MI, the different types and characteristics. For instance, the dysrhythmias, the left ventricular failure, and pericarditis as a few examples. There are some resources from the American Heart Association I do find very helpful, especially when you're educating your patients and their families. It's under the optional resources located in the synchronous session schedule and links announcement. Provides some great information for what is a heart attack. When you are doing your education, you want to always find these lovely resources for our patients that easily describe. I like the mix of pictures versus and words both, because you never know how your patient learns. These are just a few other examples. So now let's talk about diagnostics and labs for the disease processes. So understanding that for each condition is important. So when we think of, and I just did a quick little table here, it accurately diagnoses a patient. Diagnostic tests help identify that specific disease and condition affecting the patient or rules out other conditions. So monitoring disease progression, lab tests can actually provide objective data to monitor the progression or regression of a disease over the course of the treatment and time. It helps us with evaluating treatment efficacy, detecting complications, screening and prevention. Again, patient education. So we want to make sure that they're understanding why these labs are being ordered. So it helps them understand the reason we need to order it, the importance of compliance and adherence as well. All right, some of the first examples, if we look at STEMI, so on our STEMI, we talked about ECG, even coronary angiograph or angio. Lab tests can include those cardiac biomarkers like the troponin, CKMB, CBC. We may see a CMP, coagulation studies, and even a lipid profile. Your non-STEMI, you have the ECG without the ST elevation. We talked about that. Cardio biomarkers, stress test, or even angio as well, coronary angio as well. So that way you can identify other issues. You see some of the same lab tests. You also may include that BNP as well to check for additional signs of like heart failure and other. Both STEMI and non-STEMI require that prompt diagnosis. So remember, our goal is to get that treatment to start to minimize that heart muscle damage. So you may see serial EKGs or ECGs. You may see serial cardiac enzyme monitoring as well. For hypertension, so we think of diagnostics, blood pressure monitoring, urinalysis to check for protein. Labs, we might see a BMP to assess that kidney function, electrocardiogram to look for left ventricular hypertrophy. Heart failure patients, we see again that BNP or NT-proBNP, the elevated in heart failure patients. So we want to look at echoes to assess the cardiac structure and function. You might see the chest X-ray to evaluate the heart size and pulmonary edema. ECGs to identify any arrhythmias or ischemia, and then a BMP to check again kidney function. A lot of times before medications that we may prescribe. Coronary artery disease, you might see the ECG stress test, the treadmill or nuclear stress test, coronary angio, even a cardiac CT or MRI. Some of the lab tests that you might see are that lipid profile, cardiac biomarkers, inflammatory biomarkers, and then of course checking for diabetes screening, the hemoglobin A1C. For DVTs, you see those D dimers. We know that it's going to be elevated with clot breakdown. You might have a duplex ultrasound of the affected limb, or even the venograph or MRCT venography. PAD, you might see ankle brachial index, so ABIs, the Doppler ultrasounds of leg arteries, a CT angio or MR angiograph can help. And then your lab tests are always the lipid profile, screening for diabetes, inflammatory markers. Again, we just want to make sure that we're looking at these tests. They can help with the diagnostics and just the identifying or even ruling out certain disease processes. When we're looking at cardiovascular diseases, so atherosclerosis is an underlying disease process involving that buildup of plaque within the artery walls, while coronary artery disease specifically refers to atherosclerosis affecting the coronary arteries that supply blood to the heart. Now, CAD is a manifestation or complication of systemic arthrosclerosis. The pathophysiology of arthrosclerosis, including endothelial dysfunction, inflammation, lipid accumulation, and plaque formation. It occurs throughout the arterial system. So when this process affects the coronary arteries, it leads to the development of CAD, which can cause that myocardial ischemia, angina, myocardial infarctions. So while CAD arises from the same atherosclerotic pathophysiology, it's a localized manifestation in the coronary circulation. When we think about what is the initial step of the development of arthrosclerosis and how does smoking or hyperlipidemia and even angina contribute to this? So when we think of the initial step, the arthrosclerosis development is that endothelial injury or dysfunction. So smoking, hyperlipidemia, and angina can all contribute to this. Smoking causes that oxidative stress and inflammation that damages the endothelial line. Hyperlipidemia, especially elevated LDL cholesterol, leads to cholesterol accumulation and foam cell formation in the vessel walls. And then your angina, which is that symptom of MI due to obstructive coronary artery disease. The next thing we want to think about is what are the pro-arthrogenic and pro-inflammatory or pro-thrombotic effects of elevated LPA? Why is that a significant cardiovascular risk? So if we think about elevated lipoprotein or LPA, it is an important risk factor for early onset CAD. LPA has that pro-arthrogenic effects by promoting foam cell formation, inflammation, and proliferation of smooth muscle cells. LPA particles can enter the arterial intima and become oxidized, and the oxidized LPA is then taken up by the macrophages, leading to that formation of lipid-laden foam cells. So this accumulation of the foam cells contributes to the development and progression of atherosclerotic plaques within the arterial wall. So additional LPA promotes the recruitment of inflammatory cells and the proliferation of smooth muscle cells, further exacerbating the atherosclerotic process. So the pro arthrogenic properties of LPA, including that foam cell formation, inflammation, and smooth muscle cell proliferation, significantly increases the risk of cardiovascular disease. So its prothrombotic effects increase clot formation, and the pro-inflammatory properties of LPA amplify the inflammatory process in atherosclerosis. So a high LPA significantly increases cardiovascular risk independent of other lipid levels. Okay. Next, let's talk about the role of LDL, HDL, and total cholesterol and triglycerides in CAD. So we have low LDL, which is that low density lipoprotein cholesterol, which plays a major role in the development of atherosclerosis and CAD. Elevated LDL levels lead to cholesterol accumulation in the arterial walls, initiating that plaque formation. So LDL is considered that bad cholesterol. So elevated LDL cholesterol is the most significant risk factor for developing CAD. High HDL or high density lipoprotein cholesterol is considered the good cholesterol. Higher HDL levels are protective against CAD due to HDL's ability to remove cholesterol from the arteries and transport it back to the liver for excretion. So HDL also has that anti-inflammatory, antioxidant properties. Higher HDL levels are associated with reduced CAD risk due to HDL's anti-inflammatory, antioxidant, and endothelial repair properties. HDL also has that antithrombotic effects. Your total cholesterol is a measure of all the cholesterol in the blood. So this includes LDL, HDL, and other lipoproteins. Elevated total cholesterol is definitely a risk factor for CAD, so especially when the LDL levels are high as well. And then you have your triglycerides. So triglycerides are just another type of lipid that can contribute to the development of atherosclerosis and or CAD. High triglyceride levels are often associated with high I'm sorry, with low HDL levels and insulin resistance and increased risk for cardiovascular disease. Now, when we think about familial hypercholesterolemia, what is one of the primary genetic defects responsible for elevated cholesterol levels in this? When we see familial hypercholesterolemia, the primary genetic defect is the mutation in the LDL receptor gene. So it impairs the body's ability to clear the LDL from the bloodstream. This is what leads to severely elevated LDL levels from birth and even premature atherosclerosis if left untreated. Again, I wanted to share some of the resources that American Heart Association has, and you'll find these under the optional resources. It just provides some great information for cholesterol lowering medications. Now let's quickly look at hypertension. Both these tables, 32.1 and 32.2, are from the textbook. 32.1 shows the classification of blood pressure for adults, and 32.2 breaks down the pathologic effects of sustained complicated primary hypertension. So hypertension can be classified into two different types: primary essential hypertension and then secondary hypertension. In the textbook, the table 32.1 has the great classification of blood pressure for adults age 18 and older, showing that normal, elevated, and then stage 1, stage 2 of hypertension, and of course, hypertensive crisis. So I also like to look at table 32.2 just because it discusses that pathological effects of sustained complicated primary hypertension. So going over the site of injury, mechanism of injury, and pathologic effect. So remember the renin, angiotensin aldosterone system, the RAS, contributes to hypertension by causing that vasoconstriction and sodium water retention. Angiotensin 2 is a potent vasoconstrictor that increases peripheral resistance, while aldosterone promotes fluid retention, expanding the blood volume. So in our primary hypertension, when we think about that, it accounts for about 90 to 95% of the cases and has no identifiable cause, basically. So the pathophysiology involves a complex interplay between genetic and environmental factors that can lead to increased peripheral vascular resistance, increased cardiac output, or even a combination of both. When we think about risk factors for primary hypertension, we know family history, advanced age, where we lose that elasticity, diabetes mellitus, obesity, sedentary lifestyle, stress, smoking, high intake of sodium, high intake of saturated fats, and even alcohol. When we think about, I think I have an image. Yeah. So this image is from the Pathophysiology Made Incredible Visual ebook. It provides a nice visual description of hypertension. It looks at the involvement of the kidneys, liver, and how retained sodium and water increase blood volume, peripheral vascular resistance, leading to that increased blood volume and vascular resistance, causing that hypertension. Now, in cases of persistent or chronic hypertension, the primary pathological mechanism is vascular remodeling and that end organ damage. Prolonged elevated blood pressure leads to that hyaline arterial sclerosis, accelerated atherosclerosis, and increased peripheral vascular resistance. This causes further increasing in blood pressure, creating a vicious cycle. So chronic hypertension damages that glomerular capillaries in the kidneys, increasing the protein leakage into the urine, and that's known as microalbuminuria. This is that early sign of hypertensive nephropathy. So both diabetes and hypertension can contribute to atherosclerosis through different mechanisms. Now, diabetes causes dyslipidemia, inflammation, and even that endothelial dysfunction. So hypertension leads to that endothelial injury and oxidative stress. So together, they accelerate that plaque formation. Thinking of that disease process, that can contribute or worsen cardiovascular diseases like our atherosclerosis, for instance. Both in diabetes and hypertension can contribute to atherosclerosis through different mechanisms. So if we think of diabetes, it causes dyslipidemia, inflammation, and that endothelial dysfunction, whereas that hypertension leads to that endothelial injury and that oxidative stress that we mentioned. All right. Retinopathy and hypertension, which is caused by sclerosis and narrowing of the retinal blood vessels due to that chronic pressure of endothelial injury. This can lead to retinal hemorrhages, exudates, and even impaired vision. If we leave untreated hypertension, it results in left ventricular hypertrophy, as the heart has to work so much harder against the increased afterload. So, this compensatory thickening eventually impairs diastolic filling and contractility. Now, when we think about secondary hypertension, this arises from an underlying cause. So, like conditions from kidney disease or endocrine disorders or even medications. So, the pathophysiology depends on the specific cause, such as the renovascular disease restricting renal blood flow or adrenal tumors secreting excess aldosterone. Something like that. So, secondary hypertension is caused by an underlying condition where the pathophysiology depends on the specific cause. So, such as that renal disease, that impaired kidney function that leads to fluid retention, increased renin, angiotensin, aldosterone system activity, raising that blood pressure. Endocrine disorders, conditions like Cushing syndrome, um, even primary aldosteronism distributes or disrupts that hormonal regulation of blood pressure. Renal vascular disease, so that narrowing of the renal arteries reduces that blood flow to the kidneys, and that activates pressure regulating mechanisms. Sleep apnea. So, even sleep apnea, that intermittent hypoxia and increased sympathetic activity can contribute to hypertension. So, the treatment for secondary hypertension primarily involves addressing the underlying cause. So, depending on the specific etiology, options can include like your renal artery stenosis. So, the revascularization procedures like angioplasty or stenting, ACE inhibitors, or ARBs may also help control the blood pressure. When we're thinking of the endocrine disorder like Cushing's, sometimes the surgical resection of pituitary or adrenal tumors and even just medications. Sleep apnea, we see the use of CPAPs therapy, even weight loss, and that can be helpful with treating that. In addition to treating these causes, antihypertensive medications can be used to control blood pressure until the underlying condition is resolved. We want to make sure that we're closely monitoring blood pressures, especially when the choice of drugs depends on the specific etiology and patient factors. So, teaching your patient how to take their blood pressure and monitoring or logging it, so that way they bring it to the appointments for discussion so you can see kind of a trend. All right. Now, there are some common, or the choice of medication depends on factors like age, ethnicity, comorbidities, and even potential side effects. One of the common first line medications include the thiazide diuretics. We see angiotensin converting enzymes like ACE inhibitors, ARBs, or the angiotensin 2 receptor blockers, calcium channel blockers. Often a combination of drugs form from different classes is required to help achieve that optimal blood pressure control. You do want to think about lifestyle modifications such as regular exercise, weight loss if overweight, dietary modifications such as reducing that sodium intake, limiting alcohol consumption, and stopping any smoking or vaping as well. Some of the key tests that we would run for labs include your electrolytes. So, checking that kidney function, checking for secondary causes like that high aldosterone. You want to look at urinalysis to detect the protein in the urine, which can indicate kidney damage, ECGs to look for that left ventricular hypertrophy. Echoes can assess the heart structure and function, even that. A Doppler ultrasound of the renal arteries if there's vascular hypertension is suspected. All of this helps us with diagnosing and treating appropriately. All right. Let's quickly look at deep vein thrombosis. So, when we think about the pathophysiology of DVTs, so the main factors that contribute to DVT formation are that venous stasis, the endothelial injury and hypercoagulability known as the varicose triad. Venous stasis reduces the blood flow velocity, and that allows the clotting factors and platelets to accumulate. So, this can occur with immobility, heart failure, and conditions that obstruct venous return. Endothelial injury disrupts that antithrombotic properties of the vessel lining. So, trauma, invasive procedures, or certain medications can damage endothelial cells. Hypercoagulability states increase clotting tendencies and thrombosis formation. These may be inherited disorders like factor V, or even acquired conditions like the malignancy of cancer or something. Smoking contributes to endothelial injury through oxidative stress and inflammation. So the chemicals in smoke directly damage that and dysregulate endothelial cell and function. Obesity can increase the venous stasis due to impaired venous return from the legs. It can also promote pro-inflammatory and pro-thrombotic state. So when we think of these risk factors, and all of them converging, a thrombus can develop, often starting near or venous valve. So platelet aggregation and clot propagation then lead to that DVT, including venous drainage. So this can embolize and cause a very life-threatening, what we talked about earlier, PE or pulmonary embolism. All right, heart failure, which is an inability of the heart to supply the metabolism with adequate circulatory volume and pressure. In this first image from the American Heart Association website, it shows the appropriate way the heart is to function. However, in heart failure, try to now imagine the heart as a pump responsible for circulating that water through or the blood through the complex system of pipes. So in a heart failure, the pump becomes weakened and struggles to maintain adequate flow. So the pipe becomes very narrow and blocked, increasing the resistance the pump must overcome. So additionally, the pump may become enlarged and inefficient, unable to expel the water efficiently. As a result, that water accumulates in certain areas, causing that congestion and strain on the system. That weakened pump must work harder to compensate, leading to that further deterioration over time. So proper maintenance, such as medication, lifestyle changes, can help alleviate that strain and improve the pump's function, but underlying issues remains a challenge to manage effectively. So I also wanted to share another image from the American Heart Association, which looks at heart failure and ejection fraction, explaining it and breaking it down as an educational sheet for patients. So remember, in some of the assignments that you're doing educational sheets for patients. Be creative, but you do need to make sure that you're utilizing your references, and I need to see citations, but you should be able to look at some of these examples for that as well. And remember, this should be something that could be handed to a patient and utilized for patient. Okay. This next image is from the ebook, Just the Facts, Pathophysiology, page 24. It discusses how heart failure happens in simple terms, comparing right-sided versus left-sided heart failure. When we look at left-sided heart failure, this can be either heart failure with reduced ejection fraction, HFrEF, or heart failure with preserved ejection fraction. In left heart failure, CHF, the left ventricles pumping ability is impaired. So it leads to congestion or buildup of the fluid in the lungs, pulmonary edema, and other tissues. So this congestion is the hallmark of congestive heart failure, which manifests with symptoms like shortness of breath, fatigue, and edema. While both left and right heart failure can contribute to congestive symptoms, left ventricular dysfunction is the primary driver of the congestive state in most cases. So in left, the ventricle is not able to pump the blood properly around the body. So this results in blood building up in the blood vessels that are supposed to carry the blood away from the lungs, causing the pressure in the blood vessels to increase, and fluid is then pushed into the lungs or the air sacs, the alveoli. So the clinical manifestations of left heart failure are the result of pulmonary vascular congestion and inadequate systemic perfusion. Now, left heart failure or congestive heart failure can be either systolic or diastolic heart failure. So, systolic heart failure is heart failure with that reduced ejection fraction. It occurs when the left ventricle cannot contract forcefully enough during the systole to eject an adequate amount of blood into the circulation. Whereas diastolic heart failure is that heart failure with preserved ejection fraction, and it happens when the left ventricle cannot relax properly during diastole, leading to increased filling pressures and reduced cardiac output. Now, both types impair the pumping ability of the left ventricle and results in that congestion and decreased tissue perfusion. And in systolic heart failure, the heart is and that's the heart failure with reduced ejection fraction. The heart is unable to produce an efficient amount of cardiac output to perfuse the vital tissues. Now, the cardiac output is dependent on the heart rate and stroke volume. So we know contractility, preload, and afterload influence that stroke volume. So when a person has an MI, which is one of the most common reasons for decreased contractility, it can result in that ventricular remodeling that causes that progressive myocyte contractile dysfunction over time. So other diseases such as myocarditis, cardiomyopathies, both of which can contribute to inflammatory immune changes that mediate that ventricular remodeling process. Whereas that diastolic heart failure can occur by itself or with systolic heart failure. And the major reasons this happens is due to hypertension induced myocardial hypertrophy and ischemia, which caused the ventricular remodeling. When we look at this next figure, 32.24, showing the pathophysiology of the ventricular remodeling, some of the clinical manifestations of left heart failure, we see that include fatigue, breathlessness, dizziness, confusion due to that low cardiac output. We also hear crackles in the lung basis from pulmonary congestion. You might see the dyspnea, orthopnea, a non-productive cough, proximal nocturnal dyspnea, and even tachycardia. These patients can experience fatigue due to reduced oxygenation, the heart's inability to increase that cardiac output in response to that physical activity. You also can notice cool, pale skin due to the peripheral vasoconstriction. Now, diagnostics for left heart failure include that chest x-ray showing the cardiomegaly, pulmonary edema, echo to assess ejection fraction and structural abnormalities, and then BNP levels as well. And then we have complications, which include pulmonary edema, arrhythmias, cardiogenic shock, and even end organ damage. Now, when we think of right heart failure, it can occur from left heart failure and or from diffuse hypoxic pulmonary diseases such as RCOPD, cystic fibrosis, ARDS, or acute respiratory distress syndrome. So the textbook mentions the diseases result in pulmonary vasoconstriction, pulmonary hypertension, and an increase in right ventricular afterload. So if we refer to the algorithm shown here in 32.11, I believe, yeah. It will, while the etiology most commonly arises from the left ventricular failure causing congestion, increased pressure and volume overload in the right ventricle, these acute, like pneumonia and PE, chronic pulmonary conditions can also create pressure overload in the right heart, leading to that right-sided heart failure. Now, right-sided heart failure occurs when that right ventricle becomes impaired and cannot effectively pump blood to the lungs. This often results from that pulmonary disease or prolonged left-sided heart failure. So that leads to increased pulmonary vascular resistance. As the right ventricle works harder against the resistance, it eventually weakens, causing that blood to back up in the systemic circulation. So symptoms include that weight gain, distended neck veins, enlarged liver, spleen, and even peripheral edema. Additional clinical manifestations include that systemic congestion. We see venous congestion, where that's the distended neck veins, that hepatic megalia, that liver engorgement, congestion of the liver or intestines leading to fullness, to anorexia, even nausea, so fluid retention causing ascites or anaskara. termed for that generalized edema, excessive fluid accumulation, fluid volume excess. So that's where we see that peripheral edema, weight gain, symptoms related to that impaired organ function. Some of the diagnostics include that non-invasive, like just a ECG, which can show that right axis deviation, the tall P wave, especially in lead 2 and V1, and or rhythm changes like AFib or A flutter. You can also, it's good, they'll order a echo, nuclear angio, MRI, even invasive like hemodynamic measurement. Complications include hepatic congestion, renal dysfunction, and arrhythmias. Treatment includes the management. It can be medical, surgical methods, depending on the severity and what underlying causes are there. All right. So when we think about medical, identifying triggering factors are what we need to do. So it could be caused from sepsis, arrhythmias, even that drug withdrawal. So medications such as diuretics or vasopressors, sometimes it requires mechanical ventilation. Surgical interventions can include the ECMO. And then even like a pulmonary thromboendarterectomy, which may even lead to a heart or lung combined heart-lung transplant if needed. All right, that ends this week's content session. If you again have any questions, please reach out to me via email. I hope you all have a wonderful week. Thank you.